So I'm Akhil Saklecha. I'm the Chief Scientific Officer for Acute Care at Danaher, as well as an emergency physician at Cleveland Clinic. And today, what I'd like to talk to you about is how we can use artificial intelligence in medical diagnostics to really improve patient outcomes. And specifically, we're going to talk to you about a couple of concrete examples of how we're doing it at Danaher. And I'm going to give you a little bit of clinical insight so that you'll see how the physicians and nurses are looking at AI to improve the outcomes. Now, we're a public company, so I do need to put this up there in terms of some of the comments I make and how they're viewed as forward-looking statements. First, I thought it would be helpful to talk a little bit about Danaher because it's really a company that's better known by our 30 operating companies that directly interface with customers, which can include physician offices and hospitals and reference labs and pharma and biotech companies. We're essentially a large Fortune 500 global science and technology innovating company. We have about 70,000 employees, we have 30 operating companies, and just over $30 billion in revenue. But as I said, we're better known for these companies that we have, as well as the glue that binds all of these companies together which we call the Danaher Business System, or DBS, which is really about lean management principles. But overall, what we'll be talking about today is that red box, diagnostics, which covers 6 companies and about $11 billion in revenue. When we think about these companies and diagnostics, we really take that full spectrum from as close to the patient as we can with a company called Hemoclu, which can do blood testing for hemoglobin and hemoglobin A1C. We take it through the acute care journey. We're a radiometer, where we're in ICUs and ERs. And then, of course, Beckman Coulter within central labs and hospitals, into Cepheid for molecular diagnostics, as well as Leica for anatomical pathology, digitizing images that can be used for actual diagnosis from biopsies. Now, when we think about AI, I think the way that I would look at AI is not so much on the technical side, but actually looking at it more from the clinical side. Because in healthcare, AI by itself can't really be used unless it makes clinical sense to the doctors and nurses that are managing patients. It has to have demonstrated effect so that we can make the patient lives better, we can make the clinicians' lives better, we can make hospitals run more efficiently. So that's the leaning that we'll take as I talk through a couple of these examples. Now, we'll be talking about something called clinical decision support and how AI impacts that, specifically a product called Triage Go. Now, before I get into any specific product, let me actually take you one level up and let's think about what happens in the emergency department. So I broke it up into 4 different areas. We'll call them decision points. So for those of you who I would imagine many of us here know either personally or as well as family or friends that have been to the ER, there are an initial step, which is around the triage process, where a nurse is typically interacting with the patient as they're coming in. There is a diagnosis stage, where the doctors and nurses are making their efforts to understand what the symptoms actually mean. There's a therapy or treatment stage, where we're trying to understand the impact of a treatment. And then, of course, there's the disposition stage, which is around what we're doing. Do we need to admit the patient? Do we need to send them home? And so when we take all of those areas and then we understand, okay, well, what are we doing in each stage? For this conversation, we're going to focus on triage. Okay, so when we think about triage, the nurse is sitting in a specific area of the emergency department. The patient comes in. Right away, they're making a judgment. They're looking at what is the patient there for, the chief complaint. They're looking at what are the vital signs, what are the past history, how do we make sense about this patient and understand, is this somebody that I need to take directly back to potentially an empty room in the ER, or is this someone that can wait in the waiting room? And they use something called ESI, which is Emergency Severity Index. It's a score of 1 to 5. 1 means really, really bad. Imagine 75-year-old chest pain patient who's really sweaty, got a history of diabetes and hypertension. That person is sick, can't wait, take them back. But then imagine a 20-year-old who's coming in with chest pain that's sharp, and they had just we're weightlifting. And so that's the other extreme where maybe this patient can wait a little bit until they get seen or taken back to the ER. So that would be like a 4 or 5. So that's the way to think about ESI 1 through 5. But invariably what happens is these patients end up getting a 3. How helpful is that, right? So the purpose of Triage Go is to remove that 3, decrease the number of 3s, try to move those patients over to 4 and 5 so you can focus on the ones that are really sick in the levels of 1 and 2. So Triage Go does that. Okay, now this was a product that was done very closely in collaboration with Johns Hopkins University, so a lot of the development was done there. And when we developed it, we took all of that data and we presented it to the nurse, directly assimilated into their electronic health records, so they're not having to do a number of clicks. It's actually very smooth. And what we do is we recommend a score for that patient based on that 1 through 5. And the nurse can then decide, do I accept that or not? When they do that, we found and we showed that the number, if you look over on the right side, the number of 5s increases, the number of 3s decreases. And so now you can understand, well, we got rid of those 3s. We improved it by increasing the number of people who could go into the waiting room. Now you may wonder, well, how does that make sense to bring more patients into the waiting room? Don't we want them to come back into the beds in the ER? Well, what it does is it allows us to understand and focus on the patients who are sick. Now when we think about how do we do that, right? So we take the data that's here. We take data from demographics, how old the patients are, the sex of the patient. We take chief complaint. We take the vital signs data like heart rate and blood pressure, past medical history. All of that gets assimilated together and put in an algorithm so that the nurse can then take that score, the recommended score, very quickly and ease that process to understand what do they do with that patient. Now we anonymize the data, we harmonize the data. We can customize that data specifically for a given hospital based on 100,000 or more charts that we take in, and that's where the machine learning plays a factor. And then we do continuous learning based on 2 million patient live data that we have across our customers and the research studies that we've done. And that machine learning continually improves so that we can give more and more and better accurate recommendations to the clinicians. Now, it does improve things. So think about it this way. I mentioned that we can really improve the focus on those level 1s and 2s. Well, that's what we do. We can now focus more time on the most sickest patients. We can get the intervention procedures started on them. We can get the medication started on them. We can get them admitted to the ICU or step-down units in a very streamlined manner. That's where we should focus our attention. But the thing is when we move those patients to the ICU in a more efficient way, it actually opens up beds because those patients typically would be in the ER 6 or 8 hours, and now we can move them up potentially in 4 hours. So that bed opens up to allow some of those 4s and 5s to come in. And so we showed that actually the throughput overall improves with this type of product. Now I want to tell you about something else. Okay, so monocyte distribution width. This is a biomarker that's used to help us identify septic patients early. So sepsis is a condition we call severe infection. These are the patients who are really sick, not just the simple cough and cold, but the ones who come in who are, once again, 75 and diabetic, maybe their immune system's down, they've got a bad pneumonia, but they're not able to do well at home. They need to be admitted to the hospital. Maybe their breathing will get worse, or they could go on a ventilator. How do we identify those patients really early so that we can act on them? Because we know that the faster we act and get treatment started, the better the outcome is on the patient. Now, the beauty about MDW is that one of our companies, Beckman Coulter, which makes a hematology analyzer, buries an MDW already within the most common blood test one of the most common blood tests that we order, called a complete blood count. So a CBC is a test that virtually is done in every emergency department on about 60% of patients. It has 15 or 17 different measurements that are reported to the doctor, depending on which hematology analyzer you're using. The interesting thing is, within Beckman Coulter's analyzer, is we have 100 other measurements that we don't really release to the clinicians because no one really understands how to use them, but we're measuring things such as MDW. So monocytes is a specific type of white blood cell. So when someone gets infected and we do a CBC, the white cell count goes up. A monocyte is a specific one, and what we noticed through an effort around manual analysis of data as well as machine learning is that the monocytes get activated, and we correlated it to severe infectious cases. And so we call this MDW because the standard deviation of these monocytes as they've activated in the circulating blood got to be increased and correlated to patients who were very sick. So sepsis, right? So I gave you the background about MDW, but for those of you who aren't familiar with sepsis, it's probably one of the biggest causes of hospitalization and death within the US. 50 million patients worldwide, about 1.7 million patients in the US. The cost implications about $38 billion. So obviously a very complex problem. The interesting thing about sepsis is when you look at how we diagnose it in the ER, a lot hasn't changed actually in decades. We're still using vital signs, heart rate, blood pressure. We're still using white cell count. We're still using an X-ray or urine. But think about that. That's the same stuff that we've been doing for 40 or 50 years. And so what we need to do is advance to a stage where we're using novel biomarkers like MDW, where we overlay clinical decision support, because the most pressing issue that we have right now is doctors and nurses have so much data thrown at us. We have EMR data, we have lab data, we have vital sign data, we have EKG, we have patients bringing their Apple Watches and showing us their rhythms. All of that, if you think about it from the doctor's point of view or the nurse's point of view, it's a tremendous amount of information. The other thing that we're seeing is a shortage of doctors and nurses. So now you start thinking about the experience level of these clinicians, right? So how do you take inexperienced physicians and nurses combined with this data overload, and you start realizing the implications of using clinical decision support and markers like MDW for improving patient care. So MDW is a specific marker. This has a lot of clinical evidence behind it. This is an example of some of that, the evidence as it's been published and shown in numerous clinical journals. I'll be talking specifically about one project where we use machine learning to correlate the severity of sepsis with MDW. But the key piece here is that this is FDA cleared in adult emergency department patients for identifying early severe sepsis patients when the MDW is greater than or equal to 20. So this is a project that we did in conjunction with Metro Health Medical Center in Cleveland. We used an initial population of about 188,000 patients. We then narrowed the profile. We got to 150,000. We split it between two cohorts, one for the training and one for the testing, so 75,000 each, right? And we focused on those where the prevalence of sepsis was 1.5%. And sepsis in the general population is anywhere from about 1 to 3%. So we kind of fit right within that window. Now, when we look at the results, there's a couple of interesting things to realize here. So first, and I'm gonna kind of walk this way to show you, if you look at the bottom part of the right side there where those horizontal bars are, you'll see low risk, medium risk, and high risk. So when we think about MDW, what we want to know is, from the doctor's point of view, who does the doctor need to focus on where we're worried about sepsis developing? And then who are the patients that we're not as worried about where we can then send them home, right? So low and high risk. Now the medium risk is this indeterminate or gray area. And the problem with that is when they're in the middle, it's not really helpful for anybody. So what we try to do is say, can we decrease that medium risk group, move those patients over to either the high risk or low risk, so then we can take a meaningful, actionable step on those patients. So think about this. As we look at the very top there, we're just add vital signs, right? So we're seeing these large groups, high, medium, and low. As we add in the white cell count, we start seeing some of that middle group shrinking. And when you add in white cell count, vital signs, and MDW, that medium group starts even collapsing further. So now you see the high risk groups a little bit bigger, The low-risk group is significantly larger. So now think about it this way. We have something in medicine called negative predictive value. And what that means is when the test is negative, we have actually high confidence that the patient actually does not have sepsis, right? So in this case, we have an MDW through machine learning showing that NPV is about 99%, which is great. It's a great test to say that somebody that we're seeing probably does not have sepsis and can be sent home. Now, the other benefit of MDW is it actually has a benefit in identifying these patients before they actually get sick, before they actually get septic. And so the other aspect here with machine learning is we focused on patients where we identified people who had sepsis onset 3 hours before they actually got it, right? So the value of this study through machine learning showed that first we had identified a way to identify sepsis earlier than when the patients would get it. We found another way where we have high negative predictive value. So for doctors and nurses, there's a great use case, which is low risk, send them home, high risk, get them admitted. And if they're high risk, the one thing we can do is we can start them on antibiotics because we know that the faster we start IV antibiotics on these patients, the better the outcome is. So not just that the patients become healthier, but actually that they have decreased length of stay, which directly impacts the healthcare cost. And then finally, on this slide, I wanted to actually talk a little bit about what does this mean, right? When you start thinking about using a novel biomarker, using a clinical decision support. So this was a real-world data study that we did retrospectively, so not prospectively, but retrospective. And we showed that when you look at just Triage Go alone, it was decent. The AUC means area under the curve, and the higher the AUC is, the better it is. So typically, we like AUCs of about 0.9 or above. That means that they're significant and meaningful for the health aspect of how we're looking at patients. So Triage Go as a CDS was decent, but not great. But as soon as you start adding on white cell count and MDW and NLR means neutrophil lymphocyte ratio, which is also in the CBC, you start seeing that these AUCs start increasing. And so when you look at the one all the way on the right on sepsis, you start saying, hey, that actually makes a meaningful difference. It's in a very good range where doctors and nurses understand the implications of it. So in this RWD study, one of the things we realized is that, you know what, we can actually identify patients who could be septic when the doctor is not even thinking about them being septic, right? So I gave 3 examples here. Real patients, now this is retrospective, so we're not doing it prospectively. These are a female who's 40 years old, little bit of a fever, normal vital signs, their immune system's a little suppressed, but overall, normal white cell count, not really thinking about sepsis. That person ended up getting admitted to the ICU and developed sepsis. But look at that MDW score all the way on the right? It's above 20. So this would be a patient where automatically you start thinking about sepsis, you get them treated with antibiotics, you get them admitted to the right area in the hospital. The second patient, 50-year-old, abdominal pain, normal vital signs, a little bit of an abnormal NLR, and the MDW is high. That patient ended up getting emergency surgery and died. But think about it, with MDW, if they were using it, they would have been able to identify that patient and potentially act on that person sooner. And then finally, a female in the 40s, abdominal pain, normal labs. That person became septic, admitted to the ICU. Once again, MDW above 20, actionable step. So that's the beauty of a test like MDW. But the bigger story behind this is where AI and machine learning was used to really make actionable impact for doctors and nurses to make patients' lives better. This is a product that's already out in the market, and it's now catching and available only on Beckman Coulter instruments. So that is it. Hopefully you got a little bit more insight about how AI is used in medical diagnostics and a couple of real-world examples. Thank you.